Audio is okay?
Yes, ma'am.
Okay.
Yes, ma'am.
Thank you.
And mine too.
Yes, perfectly fine.
Yeah.
Who is the target audience here?
It's mostly medical students
Huh.
who are interested particularly in interventional radiology.
Right.
Specifically put out a message
Undergraduate.
for people who are interested, mostly undergrads.
Mostly
Okay, so
undergrads.
yeah, we've gone live and I'm admitting all and I'll be starting. Okay.
Yeah.
Yeah, okay. I would request others to please keep themselves muted, except for Barbara ma'am and Dipashri ma'am, so that there's no noises coming over. Thank you. Yeah. So good morning, everyone, and good evening, Barbara ma'am. There's this lovely quote, I came across a few days ago, which was like, this morning will never ever come back in your life again. So get up and make the most of it. So on this note, let's commence today's session. I'll be sharing my screen. Yeah. Is it visible, Karthik?
Yep.
Yes, I hope everyone's done with their breakfast, so that because we have an energy-packed session full of information for you coming ahead. So on behalf of AMSA India, we extend our warm welcome to each and every one of you, and we hope this event will be beneficial to all. First of all, uh, I would like to give a brief review of what will be happening in this event, the timeline of the event. So first, we will have a small introduction to what IR exactly is. Then we will be proceeding with Women in IR panel by Dr. Hamilton and Dr. Dipashri. Then further, we have the session of clinical cases of IR by Dr. Dinesh Sharma, Dr. Hamilton, and Dr. Dipashri. And to solve all your queries and doubts, we have a Q&A session at the end. Moving forth, I would like everyone to consider some norms of the session. Please keep yourselves muted at all times unless you are asked to unmute. So this is to ensure the smooth flow of the event. Then, if you guys have any queries, any doubts, please text on the Zoom chat to any of the hosts or the co-hosts personally. Now, without further ado, let's move forth with introduction of IR. Now, introduction to IR. Now, this year we'll be doing what is IR, Women in IR panel, clinical cases of IR, and the Q&A session at the end. Now, the definition. Let's do the definition of what interventional radiology is. Now, originally, it was a subspecialty of radiology, but IR was officially recognized as its own specialty by the American Board of Medical Specialties in 2012. Now, this procedure is minimally invasive, and it is done under image guided procedures. This is done for like a various range of procedures. First, what is done is like it is very similar to surgery, but it does not require large open cuts. This is done. These procedures are usually done with needles being poked through the skin to access the vein or the arteries. So here the veins and the arteries kind of work as a highway to navigate inside the body from a pinhole in the skin. Then now what is done is the special wires and the catheters and the other devices are now used are navigated like are used to navigate through these blood vessels to actually reach the particular area of interest and then provide the appropriate treatment. Now what is happening is, if this is done, the patient can go home with a little band-aid, not with a scar or a very big open large cut. So various examples could be GI bleeds, tumors, clots, or thrombectomy, angioplasty, embolization, tumor ablation. In all these cases, IR can be used. Now, we use different imaging modalities in IR, under IR. So these are CT, fluoroscopy, ultrasound, and MR. So this was the brief introduction of interventional radiology. And now I would like to hand over the screen to Rhythm. Navneet Khurana, please take over the screen.
Thank you, Aditi. I'm Navpreet Khurana. I'm an intern and college head at AMSA India for IGGMC Nagpur. I will be moderating the Women in IR panel discussion today. I would like to extend a warm welcome to our panelists, Dr. Hamilton and Dr. Deepashri. Just to give you guys a brief introduction, Dr. Hamilton is joining us all the way from California. She is the Chief of Interventional Radiology at Desert Regional Medical Center in Palm Springs. She recently launched her book, Save Lives, Enjoy Your Own, which is a fantastic read on how to pave your path and succeed in a male-dominated field. Welcome, Dr. Hamilton. We also have with us Dr. Deepashri. She's the head of Interventional Radiology Department at Dr. Rella Institute and Medical Center in Chennai. She's also a European board-certified interventional radiologist. She is the recipient of Iconic Women Award and South Asia Women Achievers Award in Excellence in Healthcare Services category. She has also launched her own book, Art of Balance, a couple of years ago. We're delighted to have you both here today and excited to learn about your journey and experiences in the field. So let's start with why interventional radiology? What made you choose IR? Dr. Hamilton, if you could go first.
Oh, okay. Thank you for helping me unmute myself. So from the first moment that I realized what a radiologist did, I was pulled in by the imaging. So my second year in medical school, we had a pathophysiology course and we had a radiologist come speak to us. She happened to be a woman and she taught us how to find a pneumonia on a chest x-ray. And so that led me to go to a dedicated radiology elective. And that was a month long. And we got to rotate through all the different areas of radiology, which I didn't even know existed before that. And when I encountered interventional radiology, I actually encountered a gentleman. He was cursing his way through a fistulogram. So it was like a very kind of run-of-the-mill procedure. And it might not have been a very positive impression, but to me, it was pure magic. So I was hooked ever since then.
That's great. Dr. Deepashri, you can go ahead now.
Yeah. I was always fascinated by, the pictures and photography and images. This has been my passion for some time. So I definitely thought of radiology as my career. But then I never even heard of interventional radiology during my medical school, to be very, very honest with you. So as a medical student, the kind of exposure that you're giving to all the medical students over here, I wish somebody did that to me when I was a medical student myself. And nobody did that. So it was in UK that it was during my, I think, post-pregnancy, I was in my, the maternity leave. For 4 to 6 months, and I was actually doing acute medicine then. So I did medicine before getting into radiology. And during my acute medical specialty, somehow I felt I definitely need to get into radiology. And in UK, you need to do either medicine or surgery before getting into radiology. So I was doing acute medicine. And that is when I stumbled upon this radiologist, very dynamic radiologist, who I was really fascinated about. And then I just, went to him and I said, can I really, do an observership with you for 4 weeks? Because he's the most sought after radiologist in the hospital there. And, he's kind of very friendly to us. And then he would explain all the CT pictures, etc. so beautifully. And that is when I did a placement or an observership rather, for at least, I think for 6 weeks. And that was during my maternity leave. And I must say, I mean, as far as I knew, radiology was all about sitting in a dark room and reporting. But when I came across this gentleman, again, doing angios and angioplasties and really saving lives and interacting with patients, that really, it drew me very close to this specialty. And I thought, that's wow. I mean, you see radiologists who are sitting in a dark room who actually don't interact with anybody. This was my perception. And from there to seeing somebody who is so dynamic and who interacts with each and every person in the the hospital was something which drew me to this particular specialty. And that is where my spark was ignited, I would say.
Thank you. I agree. There is a need to break the stereotypes that exist about radiology. Yeah. So moving on to the next question, could you talk about your work-life balance a bit?
Is it Dr. Hamilton or myself who should take it first?
Any of you can go forward.
Right.
I don't want to go first every time. If you want to, feel free to go.
Right. Okay. The very terminology, when you call it work-life balance, I really would like to ask someone out there, what do you mean by work and what do you mean by life? Does that mean work is not life? Is my first question. Quite often we kind of divide work and we divide life. We think life is something which exists outside of our work. Rather than that, I would probably say it's more of integration of a professional life and personal life, because work is our professional life and what you call as life is your personal life, and it's more of integration. So I wouldn't actually call it balance. And the way I find I strike this integration or balance is bringing some joy at work, doing what you're passionate about. If you're passionate about your work, there isn't anything to strike a balance, I would say. I mean, I really love my field. I mean, if you choose a specialty that you would love, I don't think you really need to seek for balance elsewhere. Having said that, I'm passionate about a lot of things. I mean, I'm a fitness freak and I love Zumba. I love working out. I love dancing, and I just do this every 2 hours in the morning. It's my me time. Morning 5 a.m. to 7 a.m. is my me time, and then I spend time with that. And I suppose that's what helps me strike a balance. But I wouldn't call it a work-life balance. It's more of integrating your professional and family life and bring passion to work. Yeah.
Awesome. Thank you.
Yeah, I write a lot about this on my website. I've been blogging for 2 years about this because I think it's a really interesting question. I think it's a misconception about a lot of the male-dominated fields in medicine. So whether it's surgery or subspecialty or radiology, these are all male-dominated fields where people are still telling women that they don't belong because there is no balance. And I disagree. So, as far as the wording and the semantics, for me, it's more of an intangible thing. And I just have felt the need to share that it does exist. It can exist. And I think it's a function of your choices. And so that's what I write a lot about on my website, tiredsuperheroine.com. And it's just, I have just felt driven to share this life because I have such a great life here. And, all along the way, people were saying, this isn't really for women, or don't you want to go home at 5 o'clock? And it's like, well, sometimes I go home at 3 o'clock in the afternoon, and other days I go home at 9 o'clock. But when I am there, I am needed. And yeah, to what Dr. Deepashri said, it's because when I am there, I am in the zone and I'm doing something that's important to me. And it's obviously important to the patient and their family. And I just feel very engaged by that. But I do believe, you can't be at work every day until 9, or you don't have a balance. And so I think, part of the balance, to me, in our field, it's kind of a work hard, play hard kind of balance.
Awesome. Thank you so much for those suggestions. Moving forward, as a student, I know mentorship has played a key role for me to explore new ideas and get involved with research. I would love to know how important mentorship has been in your careers, and how do you propose students approach mentors like you for guidance and support?
I mean, I would definitely say it played an important role. The reason why I'm an interventional radiologist today is because of a brilliant mentor that I had during my training days. In fact, pre-radiology training, I would say. Much before getting into this particular field, I applied for so many jobs in radiology to start with, and every time I got declined. There was only one person who I would go up to, and he's none other than Dr. Robertson, who was then the regional advisor of Yorkshire Deanery, where I got trained. And every time I would just go to him because I really would have no clue. Sometimes you would want to give up early in life, and sometimes we are not that self-motivated, and we need somebody to kickstart for us, and that is where the mentor's role comes in. Somebody to kickstart us, and somebody to motivate us, and somebody to say and put us in the right direction. And he was the person who actually put me in the right track and in the right direction. Otherwise, I probably would have completely gone off the track, and I would have taken up a specialty that I was not designed for. So that is where the importance of mentorship comes in. And yeah, that's about it.
Yeah, mentorship is so important, but I think we put a lot of pressure on students to find a mentor, and I think it's hard to do. So I just remember feeling really intimidated by the concept. And so the Society of Interventional Radiology has done something to try to help that. I mean, we used to just have a roster of names, like you would just have somebody's name and what state they were in. And it was up to you if you wanted to find a mentor who wasn't in your institution, you could just cold call this person. Obviously from India, it would be harder to do that, or you could just email them. Now they actually have an infrastructure. So they have this electronic database where you can find a mentor, which is really helpful because you don't know just by having someone's name there, what they're interested in. Do they have, your organ system that you're interested in? Are they interested in that? Or are they in private practice, or do they have an interest in research? So all of these things are important when you're choosing a mentor. And then beyond mentorship, sponsorship is something that everybody needs. So, I found it helpful to just assemble like a roster of mentors. And I don't know if anybody's ever seen that wheel, but you can have like a whole panel of mentors, and some may be stronger in some areas, whereas some may be stronger in other areas. And you can have kind of like an advisory panel, like you're a big corporation. So that's a nice way to do it. And it also takes the pressure off one person to, like, as far as the time pressure and just the pressure to know it all. So yeah, I think it's really important. There are definitely some online resources now. And I think having role models is really important. So even beyond somebody like taking me under their wing, which has happened various times in my career, just having a role model where you can see someone who looks like you or somebody who you can identify with, I think that's really important too.
Awesome. Thank you. I'm sure this will be useful for the students attending the panel today. And Dr. Hamilton mentioned the Society of Interventional Radiology, and I would just like to add that it's free for all medical students, also international medical students. I am a member of SIR, so it has great resources, and if you guys need any help with it, just hit me up. All right, moving forward, as a closing question, I would, if you guys have any advice for women who are interested in IR and other male-dominated fields.
Yeah. So when it comes to India, especially, quite a lot of women, they back off when it comes to IR, because one of the most important things, or the perception rather, is it's some people, they tend to think it's a male-dominated specialty, and then others seem to think it's a 24/7 service. So, you need to be there any time of the day. If there is an emergency, you've just got to be there. And that actually, pushes them away from this particular specialty. They don't choose this specialty. That is one category of women. And then we have another category who really are interested in getting into IR, but probably because of the lack of mentorship, or there's nobody to guide them, or lack of accredited fellowship training programs, or they might not choose the right. We have these restrictions that you need to be in a so-and-so city. You can't get out of the city if you're married, and then you have to leave your kids and go to another center and then work there. So there are a lot of restrictions that way. But then one piece of advice that I would say is, it's more or less like, let's say if you love someone, no matter what, you would just go and you would do your best, and then you would get that person, won't you? So if you love a specialty, no matter what, it's just a matter of 2 or 3 years. And I think we just need to put in our heart and soul into it, work hard for those 3 years or 4 years of your time, and that's it, your life is done. So if somebody is really interested, any woman for that matter, it's and the desire to do this particular specialty, it has to come from within. There are certain things that you really cannot instill into people, because there are a few people who do not want to pursue this specialty. We cannot push them to take up IR. But if somebody has got that burning desire to take up IR, I don't think anything for that matter should stop them. We can survive in any specialty, and I'm surviving so far, and Dr. Hamilton is surviving. So I think we need more women in IR, and I would encourage, if you're interested, to take it up.
I so agree. My message in my writing and whenever I speak to people is not to settle. So I find it really interesting to hear about all the extra barriers that women are dealing with in your country where there are so few training programs, or if any. But it is very important that, you don't settle, because medicine, no matter what you do, is demanding. And so you might as well do what you really love. And apart from that, don't be dissuaded by people who are naysayers. So, I mean, even in the US, a lot of people look to us as leaders. And despite that fact, there are only 8 to 10% women in IR. So we're not doing a great job of attracting and retaining women. And there's really not a good reason for it. So don't be scared off by that. That's my advice.
Great. Thank you so much for such a motivating and enlightening session, Dr. Hamilton and Dr. Deepashri. Now I would like to introduce Karthik, who will be taking over the case discussion session with our esteemed speakers. Thank you so much, everyone.
Thank you.
Thank you.
Hello, good morning, everyone. I'm Karthik. I'm a third year medical student at IGGMC Nagpur itself. If any one of you have missed the previous session, Women in IR, by any chance, I'd like to reintroduce them. We have an esteemed panel for you guys. We have Dr. Barbara Hamilton, who is joining us from California, and who will be speaking on the scope of interventional radiology and application of interventional radiology in trauma management. We have Dr. Deepashri with us as well, who will be covering interventional oncology. And later on, we'll also have Dr. Dinesh Sharma, who will We'll also have Dr. Dinesh Sharma, who will be joining us for his topic as well, who will be covering interventional neuroradiology. So another note, guys, Dr. Barbara will have to leave us after a session. So if you have any questions for her, please type it in the chat box itself here, or in our YouTube stream as well. We'll be addressing them after her talk. So I'll let Dr. Barbara take the spotlight now. Thank you.
Thank you so much. Okay, it says I'm screen sharing. Is that true? Can you see?
Yes, ma'am.
Okay, perfect. Thank you for that lovely introduction. And again, thanks for having me tonight. It's an honor to be asked. And so I am going to go over vascular and interventional radiology, just an overview of what we do. And also I'll be transitioning halfway through the talk into some trauma cases. So I'm Barbara Hamilton. I'm the Chief of Interventional Radiology at Desert Regional Medical Center in Palm Springs, California. I'm 2 hours east of Los Angeles, and I'll explain who this guy is in the corner in just a moment. Okay, so I'll be going over a brief introduction of IR, just history of the specialty, some of the team members who I work with every day, and some of the IR tools that we commonly use. We'll be talking about different categories of IR procedures, and we'll talk about patient consent and prep. So that's important for the medical students here, which I guess is all of you. And we'll finish up with some trauma cases. So just feel free to stop me at any point if you have any questions or need something clarified, okay? So you can see here that it's a busy slide. This is the history of interventional radiology when it's put out in bullet points with some of the key innovations which have come out of our specialty. And so in 1964, we started with the first angioplasty, and just it accelerated from there. Self-expandable stents in 1985. I mean, this is a very exciting field. It's a young field. So just to give you, a broad overview, I don't expect you to read this whole thing right now. When we talk about vascular and interventional radiology, I'm glad to see that you have both sides represented today. I myself identify as a body IR, or an interventional radiologist who works below the neck. And that's as opposed to neuro IR, which are our colleagues who work across the hallway, and they do things like vessel recanalization in stroke, and they coil aneurysms. On the body side, we have a little bit of overlap in that I do some spinal augmentation. So I do kyphoplasty and vertebroplasty for spinal fractures. So I thought the introduction was fantastic, talking about using the blood vessels as a highway that we use for our procedures. And aside from the blood vessels, I like to just use the umbrella term of plumbing, but some people confuse that with, they think I mean like endoscopy. So we also work, aside from the blood vessels, within the biliary system, within the genitourinary system, and of course in the arteries and veins. So some of the procedures are listed here. So who makes up the IR team? It's really important to know that IR is a team sport. So, we have a lot of long catheters and wires. We have a patient who's on the table under sedation. So there are a number of people who need to actually come together to make that happen, to make a minimally invasive procedure happen well. So there's someone like myself, the interventional radiologist. There are the IR technologists. So these are X-ray technologists who undertook additional training to become interventional technologists. In this photo, you see these three on the side are techs that I have worked with for many years. And the technologist acts as a first assist. So it's like if this were a surgery, which patients see this as a surgery, the technologist is there as your right-hand person. So they're acting as a first assist. And then we have 2 nurses in each case. This is really helpful. The nurses have usually ICU level and or ER experience. And some of our patients are quite sick. So it's very helpful to have these, high-level nurses with you monitoring the patient. As far as the minimally invasive toolbox, we use a number of different things, and I'll just highlight a few here. Hopefully some of you have had some exposure. This on the top is a picture of an ultrasound, and this is the jugular vein and the carotid artery. So this is a common highway or pathway that we use to do different procedures, from placing a venous access to doing a TIPS procedure or a shunt through the liver. So the jugular vein can get us a lot of places. And this is a specialized wire. You can see it's got a curve at the tip. So this is an atraumatic wire that we can drive through the body. These are little plastic tubes called catheters, and they come in various sizes and shapes, and they help us to navigate different places within the body. And down here at the bottom, this is a balloon catheter. So this will go over a wire to actually target an area of disease, whether it's in a dialysis access, fistula, or in a lower extremity, and it can help us to open up the vessel with a minimally invasive technique, and that's called angioplasty. Down here at the bottom, we have some microspheres, and I'm sure Dr. Deepashri will cover this, but we use these for interventional oncology applications, and we also use them for benign tumors like fibroid embolization. So the bedrock of IR, one of them is venous intervention, and part of that is just having solid venous access for certain patients who need it. So patients who need it include dialysis patients and cancer patients. So these are a couple of examples of dialysis catheters that we use, which we can place into the large veins and guide them toward the right side of the heart. And that allows for us to rapidly exchange the blood at dialysis for these patients. And these catheters, sometimes they need maintenance or exchange. And so the IR team, sometimes we'll see these patients longitudinally for that. They'll come back to get a catheter put in. Once they have their dialysis fistula, maybe they'll come back to get the catheter taken out, and so on. And down here at the bottom is an example of a port catheter, where this is a chest x-ray. Sorry for the toolbar there. And on the right chest wall, and you can see that the catheter is going under the subcutaneous tissues to dive into the jugular vein here. It's a little bit hard to see. And then that catheter tip ends usually in the cavoatrial junction. Another area that we are commonly asked to help out is in the case of a GI bleed. So this is just a quick case to demonstrate that. This was a patient I had who was a 56-year-old with pancreatic cancer, and he was status post common bile duct stent placement with a 3-week history of melena or dark tarry stools. So this patient was hemodynamically stable, somewhat coagulopathic with an INR of 1.3. Platelets were normal and the hemoglobin was dropping. So I have a video. Let me see. And you can just tell me if you can hear this. Please let me know. Can you hear that? So this is the patient's CAT scan in planning for the angiogram.
Dr. Hamilton, I don't know if anybody's listening, but I can't hear it actually. Is everybody able to hear what's happening there?
Oh yeah, I was hoping you could hear that.
We are
Yeah.
only able to view it, ma'am. We
Yeah.
are not able to hear anything.
Oh, I'm so sorry. Okay. Please
Ma'am,
feel free to speak up if we're having some issue. Okay. So basically, okay. Do you want me to run through that? I can just,
ma'am, maybe you can just like share your computer audio so that like then we'll be able to hear maybe.
I don't know how to do that. Okay. Oh, right. Because it's just coming through my microphone. Okay. So I will just explain as it's going through the images. Is that okay?
Yes, ma'am, totally fine.
Okay. So to start out, we are going through the CAT scan of this gentleman who has a pancreatic malignancy. I'm pointing to the atrophic pancreas, and this, you can see the head of the pancreas has a tumor, and that's a common site where we have a dilated pancreatic duct. This is all tumor, and you can see a palliative common bile duct stent going through that area and coming down into the duodenum, which looks abnormal. So this gentleman was having melanotic stools for a couple of months, and basically the tumor was invading into this area and causing bleeding. So here we have the celiac axis. So I entered the common femoral artery And using over a wire, I used a catheter to engage the celiac axis. So that's where we are now. So this is the patient's right, and this is the patient's left. And this is in the epigastrium. You have the celiac axis. I was just pointing out some of the anatomy. So to get to the blood supply for the duodenum, you engage the celiac axis, and this is the common hepatic artery, and this is the proper hepatic artery, and coming off, they're basically, the landmark is the gastroduodenal artery. So that's a common vessel sacrifice that we can do if a patient has a bleeding ulcer, or in this case, they have a tumor, which is affecting this vessel. You can actually see that blood vessel is kind of thinned and irregular in that area, and that's a sign of invasion. So this is a celiac angiogram that you're seeing right now. And then the imaging is not so hot, but basically the way that I get my catheter all the way into that smaller vessel is by using, within the 5 French catheter, which is the larger catheter in the celiac axis, I can place a smaller catheter called a microcatheter into the gastroduodenal artery. And that allows me to embolize the gastroduodenal artery. So any questions about that? So this is a gastroduodenal artery embolization. This is a common target for upper GI bleeding. And the final thing I say in this clip, I do a superior mesenteric artery angiogram, and that it shows some of the collateral supply to this area. So since the upper GI tract has such good collateral flow, a vessel sacrifice is generally not going to cause ischemia. So if you have any questions about that, feel free to pipe up. And I'm sorry about that. Okay. So for GI bleeds, we're often called in interventional radiology to help with lower GI bleeds as well, but those statistically are far more likely to stop on their own than upper GI bleeds. It's important to know when you're evaluating a patient like this, whether gastroenterology has seen the patient, and they can help you to localize the bleeding, like in the form of an endoscopy. Sometimes they can go in and see that there's a bleeding vessel in the gastric fundus, or they can tell you there's a bleeding ulcer in the duodenum. So it's very helpful to work with your gastroenterology colleagues. And likewise, this applies with all the other specialists that we work with in IR. We have a close working relationship because we help each other out. And then to work up a patient with a GI bleed, or this applies to some other patients who are bleeding as well, we often get a CTA of the abdomen and pelvis, and that's preferred. And that's a great way to localize the bleeding if you haven't been able to localize it in any other way. So a CTA is a multi-phase CT study, which is usually a non-contrast study followed by an arterial and a venous phase. You can also do a delayed phase, and that can show active extravasation, or the contrast actually coming out in the bowel lumen. And it can also show an underlying cause for the reason, for the bleeding, such as diverticulosis or a mass or an AVM or varices. So that's kind of helpful for no matter what field you end up going into. We all see GI bleeders. So this is another example of a common quandary for IR. Patient presents to the ER with a cold leg. And does anybody want to actually, you can feel free to tell us what you see here.
If anybody wants to speak, you can raise your hands so that we can unmute you.
So this is before these two images, and this is after we did our work.
So we can see the supply being cut off near the knee joint there. And also a soft tissue swelling, if I'm getting that right, the lower limb.
I like how you said cut off. Yep, I see an abrupt cutoff, a filling defect in the popliteal artery. So you can see the contrast coming down here from the angiogram into the superficial femoral artery, which is the main artery of the thigh that brings flow below the knee. And you can see this below the knee angiogram shows almost no flow below the knee. So this patient is this is an acute occlusion. This patient has not had any time to develop collateral blood supply, which happens over time. So this is an acute occlusion. And this is what the artery looked like after we did our work. So we opened the leg back up by doing a lower extremity arterial lysis procedure. So we put a catheter up and over the aortic bifurcation and dripped TPA overnight, which is an enzyme, a concentrated enzyme to break up the clot. And that helped to restore blood flow. And so what would you like to know about this patient? If anybody has any ideas, you can raise your hand, or I can just keep going for the sake of time. So this patient actually has atrial fibrillation, which is a common reason why patients can form clots in the atrial chamber, and basically those clots they can go north and cause strokes. They can go in all different parts of the body. I've actually seen, clots in the mesentery, which is like a stroke for the gut. So these patients can be affected by this problem, like a cold leg. And so what tests should be performed next? Well, usually echocardiography is the next step. So you want to see if there's any clot that can be identified within the heart with ultrasound. So pivoting a little bit, this is, I found this online. It struck me as kind of like a cartoon or like a simulation. It's kind of too perfect looking. But we all know this lady had a kidney procedure, and it was, because of privacy, we don't know exactly what it was. Hopefully everybody recognizes that's Melania Trump. She is our first lady, outgoing. So this is an angiomyolipoma, and this was the benign mass which she was speculated to have treated. And this is a common target for embolization. In the news, they said it was a benign mass that was treated. So the speculation was it was this kind of mass. So you can actually have multiple angiomyolipomas. This is a patient with tuberous sclerosis. So that's a very abnormal appearance with multiple AMLs. And you actually, you don't necessarily need to have these treated unless they reach a certain size. So some are just sub-centimeter masses. We don't necessarily do anything with them. Sometimes they're just, we call them incidentalomas. But other times, this is an example I found online, which is kind of a larger case. This is like a 3-4 centimeter mass, and these can actually bleed with increasing size. They have an increased propensity to bleed. So I thought this was a nice case. This shows a renal angiogram of that mass, and you can see the kind of tumor stain out here beyond the confines of the kidney, which matches this coronal CT image here. And you can see this, in this case, they put the catheter into the renal artery. And it looks like they were, so this is a parenchymal phase where you see more tumor stain over time, whereas this is like the initial arterial phase. So this is sequential phases. And they blocked off multiple tumor feeders using coils. Some people also use alcohol for these. So they'll actually embolize with alcohol. So a little tidbit about our first lady. That's what we think that she had done. So in interventional radiology, it's important to realize that the big difference with surgery is that most of our patients are getting their procedure done with moderate sedation. And so where I practice, that tends to be Versed and fentanyl. And so Versed is a benzodiazepine, which is like an anxiolytic. And it also has amnestic effects. So it's important to warn the patients about that. After they have sedation, they need a ride home. They can't just, take a taxi home by themselves. To get sedation, they need to have nothing by mouth for 6 hours with the exception of just pills with sips of water. And that's because if they have sedation, then if there's anything in the stomach, it could, go down into the pulmonary system and cause aspiration. So while we're doing moderate sedation, the patient actually maintains their own respiration, and they're monitored by a dedicated nurse, or in our case, by 2 nurses at all times. And then it's under the supervision of myself. If I'm doing a more complicated case where I actually need an anesthesiologist, occasionally I will get the help of an anesthesiologist. Like when I do a shunt through the liver, that's an example where I actually do general anesthesia. Any questions about that? So it's really important to learn about informed consent when you're going through interventional radiology, or any procedures in radiology for that matter. So across the board, when we're using a needle to accomplish different things, whether we're puncturing a blood vessel or an organ, the risks related to the needle are generally of bleeding, infection, and pain. When you're accessing particularly an artery, there's a chance of an access site hematoma. That's usually quoted at 5% or less, depending on the patient's coagulation profile. There is exposure to radiation. You may warn your patient about that if you think it will be a particularly long case with lots of radiation. Perhaps that tends to be more common in like a neuro case. There's always a risk of allergic reaction to the contrast that we're using in the vessels and organs. There's also a risk of allergic reaction to the medicines that we use for sedation. And then some procedures have a very specific risk profile. So an example of this is a lung biopsy, where the risks include pneumothorax or collapsing the lung, coughing up blood, which is called hemoptysis, or the dreaded air embolism, actually getting air sucked into one of the pulmonary vessels. And that can cause circulatory collapse. So kind of a scary one. When we're doing angiography, the risks generally include things like vessel damage, perforation, dissection, occlusion. And of course, the risk increases if there's underlying arterial disease there already. So these things are far less common if you're doing a procedure in a person with relatively healthy vessels. Okay, and so now we're in the second part of my talk. Hopefully we're okay on time. Looks like we're just in the middle.
Yes, ma'am, no problem.
So any questions about that before I move on to some trauma cases? Okay, I'll go ahead. So I work at a level 2 trauma center. I'm out in the desert in Southern California, and we have lots of all-terrain vehicles. We have lots of people flying, airplanes for as a hobby, and we have all kinds of trauma from the highway. So we tend to see quite a lot of trauma, pretty much, just as much as a major metro center. So even though I'm kind of in a little desert resort community, it tends to see a lot of trauma for that reason. So this is a talk that I gave for the Western Interventional Next Gen Symposium in LA last year. And I, to see the full talk, you can see it on YouTube. If you just Google Barbara Hamilton, MD, trauma in the community, you'll find my YouTube channel, and it has the full talk. So I'm just going to do an excerpt from that talk. And one of the things I wanted to highlight is the standards of practice article from the Society of Interventional Radiology. This was co-authored by one of my mentors at UCLA, which is where I did my interventional radiology fellowship. So John Moriarty, who you'll see on the top line there, is one of my mentors. And this goes over an amalgamation of the evidence that we do have for, the various levels of evidence for treating trauma patients in the way that we do. So it's a helpful document, and it's helpful, if for nothing else, than to see, how little data we have for some of the things that we do, because trauma is sort of a difficult population to study. So with that, I'll show you some cases. This was, I don't know if anybody celebrates Thanksgiving, but this was on Thanksgiving Eve one year. A few years into my career, I had a call from the surgeons that there was a 19-year-old with a stab wound. Apparently it was self-inflicted, and she went to a different hospital down the road where they don't do trauma. So they brought her later to us after doing this CAT scan. And you can see here, this little speck is the internal mammary artery. It looks normal on the right side, and this is where the stab wound was inflicted. So it's to the left parasternal border, and you can see you kind of lose the internal mammary artery there. And here you can faintly see it. So maybe there's a bit of arterial spasm. And here you have a large hematoma in front of the heart. So there's a mediastinal hematoma. Excuse me. So my surgical colleagues asked me if I could, save them from having to crack the chest and, do some kind of mediastinal packing or repair. And of course, for interventional radiology, this is like much easier. This is why we do minimally invasive procedures. We can simply enter in the right common femoral artery under ultrasound guidance. We place a sheath that we work through, and over a wire, I was able to select. So we go into the subclavian vessel and then down into the internal mammary vessel here. I'm sorry for the annoying cough. So I wasn't sure what I'd encounter, whether it would be a vessel transection, but it's important to realize that you need to coil distal and proximal to the site of injury. And the reason is because this vessel receives collateral supply from the inferior epigastric artery. So you wouldn't want to just coil above the area of injury, because the patient could actually have collateral flow from below and could continue bleeding. So this patient did well. This was another, every trauma has a story. This guy was minding his own business when he was shot in the rear end. And this is buckshot. So you can see on this axial CT image that, he has a lot of soft tissue swelling and soft tissue gas. And he had a bullet entry wound in the kind of outer gluteal area. You can see a comminuted fracture of the sacrum here, and he has all these pellets in the pelvis. Here you can see there's a pelvic hematoma. I think this was his rectum coming in here. And this was a hematoma developing in the left hemipelvis, and you can see a site of active extravasation. You'll have to take my word on that one. And so these are some images from the angiogram. So you can see the diffuse, if you haven't seen a lot of angiograms yet, it may not be obvious, but with experience, you would see these vessels are very thin. And so this is diffuse vasospasm because the patient was bleeding enough that his whole vascular system was clamping down. And here you can see all these ballistic fragments here in the pelvis. And over the course of the angiogram, you can start to see that he has multiple sites of extravasation developing arising from the internal iliac artery on the left. So this is extravasation here. And this is kind of more ill-defined blush. And here you can see surgical packing material. So what I did for him is I navigated, my axis here is on the right. So I navigated up across the aortic bifurcation and into the internal iliac artery. And I sprayed surgical gel foam into the artery to just shut down any area of bleeding from the internal iliac artery. This is a little different rendition of pelvic bleeding. So this is a 69-year-old gentleman who fell from a ladder for comparison. And here you see his vital signs down here. Whoops, now they're covered. So you can see his blood pressure was a little soft at 86/56, and his heart rate is 72. So, he's not tachycardic. But this axial CT image shows that he had pubic ramus fractures bilaterally, but on the left, he had this pelvic sidewall hematoma with active extravasation. So this curvilinear thing, that's actually contrast. You can see the arteries are lit up here. So in the arterial phase, he had this contrast spilling out of the blood vessels and into this hematoma. So aside from the low blood pressure, this is a sign that we need to act. So you can compare this pelvic angiogram to the last gentleman who was younger. This gentleman, 69-year-old with some comorbidities, he has a more tortuous system. So you can see how the way the aorta looks like it's kind of leaning off to the side. And these vessels are a little more curvy. That's because he has long-standing hypertension. And this was interesting because over the course of the angiogram, he had this very focal site of bleeding, which you could identify. And it looked like it was coming right from the inferior epigastric artery. So it had this pubic branch. And once I made it up and over the bifurcation, the catheter just fell into this vessel. And it was a very easy select. And then with a microcatheter, I was able to put these little microcoils here. And here you can see my contrast just extravasating into the pelvis. Another interesting thing about this, this is a fluoroscopic image. And you can see that this gentleman's he has a Foley catheter with a decompressed urinary bladder, and it's pushed over to the right by the hematoma. So sometimes the fluoroscopy can show kind of, you can't see the hematoma itself, but you can see the effects of the hematoma. Okay, my next interesting case was worked together with the trauma surgeons on this 61-year-old male who was in a motorcycle crash, and he accidentally had the chest tube placed ectopically. So does anybody know what's wrong with this picture? So this is a chest tube. It's meant to be in the chest, and it actually went into the liver. So this is a coronal CT image. So we're slicing the patient this way, kind of like we have X-ray vision, like they're standing in front of us and we can see this is their right side with the liver. This is their left side with the spleen. And I think he had just a trace pneumothorax and a little bit of fluid they were trying to get, but they aimed too low and ended up in the liver. And so they asked for my help. And so what we ended up doing, this was a nice example of coordination between the trauma team and the interventional team, because I was able to go in and I cannulated the hepatic artery. I was specifically, just based on the cross-sectional imaging, I was worried about the right hepatic artery, because the chest tube was in the right hepatic lobe. And I did an angiogram and carried it through to the portal venous phase. I did not see any extravasation on either phase. And here on the digital subtraction, you can see the chest tube right there going through the dome of the liver. And so the trauma surgeons came by and they actually removed the chest tube after this initial angiogram, and leaving my catheter in place, I was just simply able to repeat that angiogram. And if there was going to be any problem, if removing the tube was going to damage an artery or cause extravasation, I would be right there to treat it. And this gentleman did fine. So we were lucky. I'm lucky about that chest tube mishap. Just flag me if I'm running out of time. Okay, I think I'm running short on time. So much trauma. So please look up that YouTube. The full talk is called Trauma in the Community. You can find it if you search my name. So this was a gentleman in a motor vehicle crash, and he had displaced rib fractures. So the reason I thought this was interesting to show is that we don't often see active extravasation into the pleural space. So again, this is a coronal CT image, and you can see the contrast spilling out into this large pleural effusion. And so this was one of the intercostal arteries from the displaced rib fractures was actively bleeding into the pleural space. And the pleural space is one of the body cavities that, you can bleed very rapidly because there's no compression. So there's nothing to stop the bleeding really. And so we were worried about this, and I was asked to intervene. And so again, using the right common femoral axis, I was able to cannulate one of these intercostal arteries, the affected artery, based on, you could see the rib fractures on the fluoroscopy. And I did not see any active extravasation on the angiogram, but it's okay to do empiric embolization of these intercostal arteries. So you can see the displaced fracture here. You see that big step off. It takes some practice, but and then there's another displaced fracture here. So just based on where the extravasation was on the CT, I knew which level I wanted to target. Okay, so just speeding up here, this guy fell asleep at the wheel and he fractured his spleen. So, if you want to go back and see that, I did this is a super selective embolization of a splenic branch that was bleeding. This was a young gentleman who was stabbed in the back, came in a few hours later, was not feeling well. And these are some CT images showing his large pseudoaneurysm from that stabbing. This is the angiogram. So this is his right kidney. You can see that there's this big pseudoaneurysm and there's early filling of the renal vein. So this is an AV fistula. So it's a traumatic AV fistula. This is a big problem. And so I treated that using some coils where, we're basically trying to save the kidney, because if I don't coil off part of the kidney, the whole kidney is going to come out at surgery. So anytime, that's one of the beautiful aspects of interventional radiology is, we can save the spleen or we can save the kidney, because if the surgeons go in there, it's just going to come out. This is too difficult to control for them. Okay, and this final image just shows a nice example of arterial spasm. You can see this little beaded appearance that wasn't there before. So, becoming a doctor is not easy. I commend all of you for being where you are right now. And I just want to let you know that I have this resource on my website. If you want to hear about, how I became a leader in my department, I had all these nasty, really awkward failures along the way. And it's just, I want to normalize that because, it's not an easy path. And if it were easy, everybody would do it. So you can get that audio resource on my website. It's called 7 Things to Keep You Going Strong on the Path to Becoming a Physician. And it's specifically for people who, want to be surgeons, but, it's for everybody too. And IR is still a really male-dominated field. So if you Google IR, these are the images you'll see. You'll see a couple of guys in purple caps. I don't know why they have these fancy purple caps. But I hope with my platform and just by speaking to all of you that I can move the needle and just try to get some more women into IR. This is me at work. So I'm engrossed in my work. I just love what I do. Just like Dr. Deepashri and emphasized. And, but we're growing in numbers. And this is an image from a couple of years ago at the Society of Interventional Radiology. We had a women in IR reception. So you can see that although we're spread geographically, we're all spread apart. We do exist. And these are some smiling faces to prove it. And here's my book. If you're interested to check that out, this is just some of the things that I talk about in the book. I think it's really important that we pick the right career to begin with. And in this book, I'm speaking to medical students, not just those who want to do IR, but those who want to work with their hands, people who are considering whether they want to save lives, whether it's worth waking up in the middle of the night, and all of those beautiful things. So thank you so much for having me. And here's how you can keep in touch with me.
Thank you so much for the insightful session, ma'am. We don't really get exposed to a lot of these cases and images in our undergrad studies. So thank you so much.
Yeah, thank you.
We'll now move on to the Q&A. We have a couple of questions. There's this notion around here that it's really difficult to get into a radiology residency or a surgical residency for that matter in the United States. So I wanted to ask, how difficult or easy, according to you, is it to get into a radiology residency in the United States?
For someone who is graduating in India?
Yeah, for IMGs.
Yeah, for IMGs, it's very difficult. Interventional radiology is the most, it was statistically one of the most competitive fields to get into, even for people in the US, graduating from US medical schools. So it's incredibly challenging. But that said, we need IRs all over the world. And I've seen a lot of people make it work by doing different research fellowships, by making connections, and just by sticking with it. And so, some people have been able to jump the pond by doing research fellowships in particular and making relationships. So, I think it's difficult, but it can be done.
Okay. Another question we have is, apart from the USMLE STEP scores, how important is it to have research experience in the field of interest?
A lot of people will say that it's important. I never considered that my strength. So I would just say that, if you are a well-rounded candidate who has something else going for you, the research is not the be all end all. If you don't feel, I would at least give it a try, see if you can get involved in some research projects, because it not just, even if you don't have the most genius project or the most amazing publication in the end, you will gain a valuable experience and hopefully some knowledge in the process. And, if it's not a specific area of research you're able to get into, sometimes you can just get involved in educational projects. That's how I got started. So like putting together educational resources for other students, and just something like that can be a really good resume builder.
Thank you so much for answering, ma'am. I'd like Dr. Avi to take over now. Avi, if you're there.
Am I audible?
Yes.
Yes. Hi, Dr. Barbara. It's been a pleasure to have you with us. It's been such an insightful session that we've been able to hear you. All the organizers, they've done an amazing job in making this possible for us to have so beautiful insights. I don't know how many final proper interns do we have here, but I being one, like intervention radiology has always been one of those subjects that has been a mystery. Like we want to know more about it, but the exposure that we have clinically or even theoretically is not really a lot in the medical setup in India. But I'm sure a lot of people here will now actually start believing that radiology is not just radio diagnosis, it is as much interventional radiology, right? And ma'am, the way that you've taken up cases and you've compiled your own personal experiences, I think there's no better way of learning the things that we've read everywhere, but seeing them practically, I think it's been one of the most beautiful, very concise, crisp experience. And I think I can say this for a lot of people, that we're looking forward to read your book and to go forward on that YouTube video that you've told us to. So I think on behalf of all of AMSA India, thank you so much for joining us. And as the VOC, I'm really, really proud of all the organizers who got this tough job done. I am really sorry that I've just gotten free from my duty and I had to attend this session because it was so lucrative. But I think it was definitely worth it. So thank you once again, Dr. Barbara, and everyone who's involved. Thank you.
On behalf of everyone, some time. I know it's pretty late out there, so thank you so much for sparing some time out of your busy schedule and delivering this talk. We'll move on with the event. We'll now have Dr. Deepashri deliver a talk on interventional oncology. So, Dr. Deepashri, if you'd like to take over.
Yeah. Thank you so much. Let me just share my screen. Okay. So thanks once again for having me over here. It's a wonderful opportunity to share our insights and share some of the interesting cases and give an in-depth insight about this particular IR specialty, which I love to the core. And I must say there is no regret taking up this specialty, and I'm sure each one of you who is willing to take it up as your career, you wouldn't regret that for the rest of your life, and take my word for it. So This is a beautiful Burj Khalifa that you're saying, and this is pretty much any hospital setup nowadays. I'm not saying every hospital is like Burj Khalifa, but what you see outside is a flashy building, but then what goes behind that is a hard work. This is something that nobody really understands, tries to understand what goes into each and every patient's care, for that matter. And all of us, we see the patient going in, coming out intact, coming out hale and healthy, but who is actually involved in the patient care? I mean, it's really sad, and sometimes it's upsetting, especially looking at the state of affairs in India, that not many people are aware of this particular specialty, which is interventional radiology. And in fact, there are so many people who see me, and when I tell myself I'm an interventional radiologist, they ask me, is that an MBBS doctor? Did you do your 5 years of medicine and got into this specialty, or is that some kind of a technician job? They think it's some other specialty. It's like a paramedical specialty. So that is the kind of awareness that we have in India, and I'm sure all of you agree with that. At least radiology specialty people are aware, but not the IR. And I would say IR, or interventional oncology for that matter, is one of the four wheels of a car. It's so important to, nowadays people go for a four-wheel drive rather than a two-wheel drive. There is no stability with a two-wheel drive, and we all know about that. And interventional oncology is one such specialty which is pretty much like a four-wheel drive. If it is not there, there's no balance, there is no stability. And that is where, our role as interventional oncologists come in. So this is what I meant. So interventional oncology, I'll just share some of the cases, maybe 4 or 5 cases, and then I don't want to bore you all with too many of my cases, but then hopefully it'll make some difference. Now, how do we make a change to a patient's life? In a nutshell, interventional oncology, it's all about adding life to years and not years to life. So you can't do anything about the length of your life, but you can do something about its width and depth. And that is what we as interventional oncologists or interventional radiologists can do to a patient. Now, moving on, for all of you who are medical students out there, let me explain to you some of the terms. Most people, even to the patients, especially in India, when we say a word like embolization, when we say a word like ablation, it sounds very alien. People are not aware of this terminology, and they think it's some kind of a fancy thing that we are planning to do. Everybody knows surgery, everybody knows chemotherapy, everybody knows radiotherapy, but they really don't know what an embolization is, what an ablation is. Now, let me break it up for you all so that we understand. These are all fancy terms, some kind of a posh name, that's it. So just imagine you're learning a new language and that's all you need to know. But in terms of the technique, it's a beautiful, beautiful technique to burn away, melt away tumors. And blocking the blood supply anywhere, like Dr. Hamilton has mentioned on her talk as well, it's embolization is whenever we block the blood supply anywhere, that is called as an embolization. And when you restore the blood supply, that is called as an angioplasty. And this is what everybody is aware of. People are aware of coronary angioplasty. A cardiologist performs coronary angioplasty. And unfortunately, it's not as popular as cardiology, as popular as coronary angiogram. Everybody knows coronary angiogram. So the way I start my talk, the way I start explaining to my patients is, do you know what a coronary angiogram is? It's pretty much the same thing. Instead of getting to your heart, I get into your uterus, I get into your liver, I get into the rest of the body. So that is where we start our conversation with our patients, and that is when they understand. So it's an opposite of angioplasty. It's opposite of restoring the blood supply is your embolization. And or just burn it, and that is what is called as ablation. So these are the 3 things which are quite integral for an interventional oncology service, other than doing the biopsies and other things, and this is what we do. So it's a huge spectrum, as you can see, but this is a whole spectrum of interventional radiology and interventional oncology. There are a lot of things that we can do. I don't think we can cover the whole thing in 15 to 20 minutes of our time. And this is again, you all would have seen this. We work through our catheters, we get inside the blood vessels and inject these particles which block off the blood supply to any particular organ for that matter. We have these fancy tubes called as catheters, which have got this nice coating so that it doesn't irritate the blood vessels, and then it just gets inside the blood vessels, and we can pretty much go in anywhere. These are maneuverable, and you can see they're so tiny. We have, in terms of French size, a couple of millimeters. So we can get inside the patient's body using this small small tubes called as catheters, as it was already mentioned in the previous talk. And this is the size of the catheter that we use to get inside a patient's body. Now, you can imagine a tumor has got a lot of blood supply to it, and the whole principle is about blocking the blood supply to the tumor. So this is a tumor. It's pretty much like a parasite which is growing inside the patient's body. And when we cut off a blood supply, the tumor is going to die. And that is the principle. And the way we do it is, it's like cutting off the branches of a tree. Embolization is more or less something called, it's called as pruning, wherein you chop off the branches or the edges of a tree, and that is what is called as an embolization. So that is what we look for when we are actually doing an angiogram. When we inject an X-ray dye into a patient, we are looking for something called as a pruning of the vessels, and that is what is the end point of the embolization. And how do we get inside the patient's body? We get to go either from the wrist, or you get to go from below the hip. So these are one of the two axes, and off late we started doing everything from the wrist. Other than few cases, we tend to go from the wrist, which is called as a radial approach. And most of the cardiologists, they use that approach. Unfortunately for us, we haven't been using it because we needed longer catheters to reach from the head to the toe. But the technology is so advanced nowadays. You get longer catheters, you get longer tubes to reach from the wrist to your liver, to the uterus, to the leg. You can pretty much reach anywhere from the wrist. Or you get in from the hip. You all know about the femoral approach, wherein we get from the hip. So the first thing that I'm going to talk about is our center is a liver transplantation center. Now, you can imagine a patient who's going for liver transplantation. They have tumors inside the liver, and there is a criteria. If I have to take out an old liver and put a new liver into somebody, the size of the tumor should not exceed a particular size. Something like maximum you're looking at 6 centimeters. I mean, although Milan criteria is something which says 5 centimeters, we cannot exceed, according to certain criteria, 6.5 centimeters. So let's say I have a patient who comes to me with a 7 centimeter tumor. Do I say, no, I can't do anything about it, I can't do transplantation for you? I mean, we can't be so hard on our patients, and sometimes we need to do something. We need to do something wherein we bring the size of the tumor down so that the patient gets to have gets a new liver, and gets on with a new life rather. So what we do first is TACE stands for something called as transarterial chemoembolization. What is transarterial chemoembolization? Transarterial is we are getting into the artery and we are using a chemotherapy drug, and we are also blocking the blood supply to the tumor. That is what is TACE all about. And we do quite a few of these TACE cases at our center. So wherein you can see somebody has got a tumor inside the liver, you take a small catheter into the liver artery, which is a hepatic artery. So this is a CT scan of a patient wherein you can see there is a tumor there. For those of you who are not aware what a CT scan is, this is like, you using X-rays, we scan people. You all would be aware of CT and MRI scans, and on the CT scan we get to see the liver. This is a liver that you're seeing, and those white structures are the blood vessels, and what you're seeing is a tumor supply. So first we identify the tumor supply as shown on this, and the next thing we do is we obviously patient counseling and all that happens, and we set up our trolley, and this is what it looks like in the interventional radiology suite. We don't have big knives, we don't have daggers, we don't have retractors. It's a simple kit. It's a very simple kit. It's pretty much like a pinhole, and this is our equipment, and this is all we use to get inside the liver, to get inside the uterus. So that's how it is. It's so beautiful that you can reach anywhere using simple instruments or the simple things like this. And this is how a trolley looks like. And then we have our catheters, which we do. This is an ultrasound. Now, how do we gain access inside a patient's body? We can get inside the patient's body using an ultrasound guidance. And on the ultrasound, we can look at the blood vessels, as you can see here. And so those dark areas that you're seeing, those are the tubular structures, which are the blood vessels. And under the ultrasound guidance, we get inside the patient's body, and then we puncture an artery under the ultrasound guidance. And that is my ultrasound probe. And that is a needle which is used to get inside the patient's body. So as you can see, I'm looking at the blood vessel on the ultrasound. I mean, we don't have to use ultrasound all the time. I mean, we don't use it all the time. We use it for a certain group of patients who are at higher risk of bleeding, and you can see the blood spurting out. And once the blood spurts out, we take a small wire inside. This is called as a Seldinger technique. The whole concept of interventional radiology, the Charles Dotter is the person who first came up with this technique, and he's the father of interventional radiology. So what we have is a sheath which goes on the top of the wire. This is like an axis. So we are establishing an axis. It's pretty much like putting a small cannula into your arms for IV fluids or whatever, and that's it. And that is our working channel through which we work our way around. So that is a basic of interventional radiology, to get inside a patient's body. And once you get inside the patient's body, what we do is we use these small tubes. As you can see, that black tube which is sticking out is a small tube, and we use these wires which get inside the patient's body. And in this case, it's a liver tumor that we are trying to target. So we get into the liver artery or the hepatic artery, which comes off from the celiac axis. So here you can see we have different shaped catheters, and this catheter will just go and sit inside the celiac artery. And once it is inside the celiac artery, we inject some contrast, which is nothing but an X-ray dye, to see whether it is sitting inside the celiac artery. Here I'm already gone with the wire inside, and that wire is inside the hepatic artery, or the artery which supplies the liver, and eventually it supplies the tumor as well. So, and that is the procedure. And then this is a chemotherapy drug. The orange stuff that you're seeing is a chemotherapy medicine. So we mix it up, and once we mix up this orange chemotherapy stuff with something called as a lipiodol, it's a poppy seed oil that we use to block off the blood supply to the tumor. And finally, we inject, there's something called as a PVA particle as well. So these are polyvinyl alcohol particles. I think Dr. Hamilton did speak about the spheres. So we do have certain spheres, and we have these particles, and then we just get into the, we inject this into the catheter to block the blood supply to the tumor. So in a nutshell, this is how it looks. I'll just mute this actually. So what you see here is catheter which is going inside, and you can see this is how, this is just a raw depiction, and we block the blood supply to the tumor. So the tumor, which was kind of white in color, it has become dark in color because there is no blood supply to the tumor, and the catheter comes out. So that is a TASTE procedure in a nutshell. So you can see the catheter which is inside the liver artery, and you're injecting the stuff. And once, this is a big, huge tumor. It's almost like the size of a tennis ball, I would say. And you know, this is vascularity of the tumor. There is a lot of blood supply to these tumors. So what we do as interventional radiologists is go in and block the blood supply. And this is yet another case wherein this patient is a young chap, actually, I think 9-year-old, 5-year-old, I don't remember exactly, but one of these patients who had two tumors, one here, and there is another tumor that you can see here. Yeah, so both the tumors were blocked. And that's how we make a difference to the patient's life. And moving on further, we have something called as an ablation. Ablation is nothing but burning the tumor. So that's the liver that you're seeing, and what you're seeing is a tiny needle which gets inside the tumor, and then we burn the tumor off. And this is how it looks. This is a radio frequency ablation. Now we also have something called as a microwave ablation, wherein we use the microwave energy to burn the tumor up. And so on the X-ray, under the imaging guidance, this is how it looks. Once we go inside, you open this umbrella kind of stuff, and then you attach it to the radio frequency current, and then you melt away the tumor. And we do combination treatment as well. On one side, we do TASTE procedure, and then at the same time we burn the tumor. If the tumor is really large, what we do is we use a combination treatment, and then we try to ablate and at the same time block the blood supply to the tumor. So this is one patient who had a tumor. That white stuff that you're seeing is a tumor which is alive. It is not a dead tumor. Once you go in and burn the tumor, this is how it looks. The dead tumor looks black. We call it a necrotic tumor. So it is black in color. So there is a tumor which is completely burnt. And a couple of weeks later, when we do a CT scan, this is a tumor inside the liver which is completely dead. A dead tumor will not take up the contrast. So it will not look white. It looks black in color. So that is how, you know, we are adding again life to the years of a patient. So, I mean, I have all these cases wherein we did a combination treatment, okay? I mean, this is a, I mean, I wouldn't go much into the details, but there are pretty much, these are all the cases wherein we went and burned the tumor. You can see on the left-hand side, the tumor is alive, but on the right hand side, the black areas that you're seeing is a tumor which is dead. So within 1 week, you can see the change in the size of the tumor as well. Again, on the left hand side, you can see the tumor which is alive. On the right hand side, you can see a tumor which is dead. This is a these are all the different cases, and this is yet another case wherein you're seeing that there is a large tumor in the liver. Yeah, this thing that you're seeing is a large tumor. I'm just scrolling and you can see which is quite irregular in shape. This whole thing is actually a tumor which is popping off the edge of the liver. And you all know that liver has got a right side to it and a left side to it. Sometimes you also probably know that the right liver is bigger than the left liver. Yeah, when somebody has got a huge right liver and a left liver, and then you have a huge tumor which is affecting the right liver, and if I have to go in and take off the right side of the liver, do you think a patient can survive just with a very small left lobe of the liver? They cannot. Yeah, a small left lobe is not enough for the patient. So what we need to do is we need to increase the size of the left lobe. Yeah, so somebody has got a large tumor on the right side, and if I have to go in and chop off the right liver, the small left liver is not enough for the patient to survive. So imagine this is how it looks. So we have the right liver and you have a left liver, and if somebody has got a tumor on the right side like that, it is and you have to take out, this is a very small tumor, but sometimes you have a really large one like I showed before. It is impossible to just go in and take out the tumor. So what we do then is something called as a portal vein embolization. You all should know by now what an embolization is. So portal vein embolization is blocking the blood supply to the right side of the liver, right portal vein supply. We just go in and we use these particles and block off the blood supply. So what happens? When one road is blocked, you have the alternative roads or the alternative channels which open up. So when you block off the blood supply to the right side, the left side has got more flow. So the left liver grows in size. It regenerates or it increases in size. We call it hypertrophy of the liver. So when the left liver increases in size, they go in and take off the right liver. So this is called as a portal vein embolization. And again, this is one of the beautiful techniques that we do. So you can see this is like branches of a tree. This is a right portal vein. You can see pretty much it's occupying the entire liver. When the entire supply is to the right side, generally the blood tends to go towards the right side and also to the left side. But when a lot of blood is getting into the right side, when not much blood is entering the left side, the left liver will be small in size. So what we do is we divert the flow to the left side by blocking it off on the right side. So here you can see pre-embolization, you have all these branches which are there, and this is what I meant by pruning. It's like chopping off the branches of a tree. So we chop off the branches of a tree by injecting the stuff, the PVA particles, the coils, glue. There are a lot of stuff. There's a lot of stuff that you can inject, and post-embolization you can see that the blood is predominantly getting to the left side. The right side is pretty much blocked. So this is called as portal vein embolization, and this is one of our cases wherein you can see this is how it looks. As I said, like the branches of a tree again. So we inject the contrast and you would see a lot of blood supply to the right side. So we go in and use these coils which are like which is made of nitinol. Some coils are made of platinum, some coils are made of steel, and then we go and block off the supply. And once you go and block the supply, there isn't any supply to the right liver. Everything goes to the left side. And so we use multiple coils, and you can see only the left side is being shown here. That means the blood is predominantly entering the left lobe of the liver. And so that is called as a portal vein embolization. And again, on this image, you can see this has got a right liver to it and a left liver to it. Okay, so you're seeing this white structure on the right side, which is a right portal vein, and another structure which is a left portal vein. And just look at the size of the left liver. It is very, very small. But once you embolize it, the left liver grows in size and it hypertrophies, and eventually the patient had the right side of the liver which was taken out, and all that you're seeing here is the left liver. Just compare it with the first picture wherein the left liver was so small, and the patient goes for surgery, and then look at it, the left liver has grown in size, and this is the amount of hypertrophy that you would expect after the portal vein embolization. Then again, moving on, some of the success stories, fibroid embolization. And again, the awareness is so bad in India that not many people are aware of fibroid embolization. Fibroid embolization is nothing but somebody who's got fibroids inside the uterus. Uterine fibroids are benign tumors. These are not malignant tumors. These are benign tumors, but over a certain size, they can become malignant, but that's very, very rare. So these are leiomyomas or benign tumors. Benign is nothing but it's okay to have these kind of tumors. tumors. But when patients become symptomatic, when patients have heavy periods, when the patient's quality of life is compromised because of these tumors, that is when our role comes in as interventional oncologists or interventional radiologists. Now, what do? Again, we do the same thing. We go in and do embolization, which is blocking the blood supply to the tumor. And it's pretty much the same thing. We use a catheter and then we get inside. So again, I'll show on this. So you can see there are multiple fibroids with lot of blood supply to the fibroid. So what we do is we get inside the fibroid, and then so that you can actually see on this. So this is a site of puncture. We use it from the wrist. Off late we started doing embolization from the wrist, but on this they are showing from the femoral root. So you can see a small tube is being taken across the bifurcation of the aorta, and then we identify the uterine artery which comes off the internal iliac artery. It's a first division, it's a first branch of the anterior division of the internal iliac artery, is the uterine artery. We get inside. I showed you at the beginning, we have very small tubes, and using these small tubes, we can reach as close to the fibroid as possible, and we can inject the stuff, and it blocks off the blood supply to the fibroid. The uterus has got a normal supply. It's just the fibroid which doesn't have the blood supply. So the patient's uterus is preserved. So we are saving uterus here. So this is called as a fibroid embolization. And I'll just share one case that I did a couple of years ago. This is a shape, this is almost like a size of a football. This patient had, I think, a 2 kg fibroid in her belly. This was the size of a football. You can see this whole thing, that round thing that you're seeing is actually the fibroid. So we went in and offered fibroid embolization, and this is how we do embolization. That's the size of the tube that gets inside the patient's body, and you can see the contrast which is being injected, and you can see the whole fibroid gets highlighted once you inject the contrast. It has got such a rich supply to it. The whole fibroid has got the blood supply to it. And so this is a pre and post embolization. Within 3 days, patient came to us, and this was we don't expect this for all our patients, but certain patients we can see this. Unfortunately, this patient started expelling the fibroid, and you can see this is how it looks. This is a fibroid which is being expelled almost like a baby. She came to us saying that something is popping out of the vagina, and what has happened is the whole fibroid is shrunken. It's become necrotic. Necrotic is no blood supply to it, and it started coming out of the vagina, and all this was taken out from the vagina. And the patient is absolutely fine, and she got discharged within a day after she presented to us. It doesn't happen for all the patients. Most of the times it shrinks and then it just melts away. But in submucosal fibroids, this is a subset of fibroids which are called as a submucosal fibroids, which are on the inner lining of the uterus. They can expel the fibroids, and this is how it got expelled. And she is the patient. I'm taking this picture with her permission, and that's her husband, and she got discharged within 2 days. I'll skip this. This is a placenta previa which I wanted to show, but this is an oncology session, so I wouldn't get into the details of this. Yeah, this is, sorry, I mean, I think the pictures are jumbled up. I can't show this, unfortunately. Yeah, and where do we make a difference? We can also make a difference in terms of the pain management as well. You know that most of these cancer patients, they have got a lot of pain, especially if you have an abdominal cancer or a pelvic cancer, they tend to have pain. What can we do as interventional oncologists? We can also do something called as a plexus block. One of the commonest plexus blocks is celiac plexus block. And again, I have done quite a few of this when I was in UK, but unfortunately in India, I didn't get to do a lot of these. I think anesthetists or the gastroenterologists, they seem to do this technique, and but this can be done by an interventional oncologist. So what you have is something called as a celiac plexus, and this is a group of nerves which supply all your visceral organs. And what we do is we inject the local anesthetic and steroid, and sometimes the alcohol as well. What it does is alcohol injection into the celiac plexus, it numbs the nerves. So patients are pain-free. And how do we do that? We can use the fluoroscopy guidance. Under X-ray guidance, we can use 2 needles to get in and do it, or we can also use a CT guidance. This is like a cross-sectional anatomy. On a CT scan, if somebody is lying on their belly, this is a prone image. From behind, from the back, you can stick 2 needles like that, because we identify where the plexus is on CT, and this is how it looks on CT, and then we can put a needle into the very close to the celiac plexus, which comes at the level of T12 and L1 vertebral body, and then we inject alcohol, and patients are pain-free. And so that is as simple as that. And my last case, Dr. Hamilton was talking about pulmonary embolism or the air embolism as well. Sometimes in cancer patients, we also come across massive pulmonary embolism, because cancer itself makes the blood thick. It's a procoagulant condition wherein the blood is very thick. And some of these patients who are bedbound for long periods of time, they tend to have something called as a DVT. DVT is nothing but your blood clots in your leg veins. And when the blood clots inside the leg veins, it migrates up into the lungs, and you can have something called as a massive pulmonary embolism. So what happens is, when there is a huge clot sitting inside your pulmonary arteries, it has got a lot of strain on your right heart. So when there is a right heart strain, people become dyspneic, and eventually they go into shock, and then they collapse. Your right heart is as important as your left heart. So this is what massive PE can do to patients. They can literally collapse before your eyes. Now, what can we do in such scenarios? You have a huge clot sitting inside the pulmonary arteries. Can we do something about it? Yes, we can do something about it. So this is how a large clot can sit. We call it a saddle embolus, which sits at the bifurcation of the right and left pulmonary arteries. And pretty much, your heart is struggling when that happens. And this is how it looked in one of our patients. Huge clot sitting there. It's blocking both the arteries, pulmonary arteries. The black stuff that you're seeing inside that white stuff is a clot. Yeah. So normally you should see nice, smooth, white walls to it. That is a pulmonary artery. That's how the pulmonary artery looks. But here you are seeing it's full of clot. When there is so much of the clot burden, what can we do? We can get inside. So you can see this is a small tube which is taken into the pulmonary artery, and then we inject the stuff. And it's difficult to explain on this picture, but what you're seeing is something called as a filling defect. Normally you should see this black, smooth stuff, but at areas and some places you see that black stuff is not seen. You have a huge clot sitting inside these pulmonary arteries, and what we do is we suck it out and we take out the clot. And there are different techniques to take out the clot. We can use something called as a pigtail catheter here. This is a pigtail which is used to macerate the clot, or kind of make the clot, literally break the clot using a pigtail. Sometimes we can use a balloon to break the clot. So here we have used a balloon to break the clot. And we have a lot of devices of late wherein literally like vacuum cleaners where we can suck the clot out as well. So different techniques were used, and eventually the patient was fine. He was a doctor himself. The patient was a doctor himself, and he was fine. So finally, this was the youngest patient who I treated. He's a 5-year-old boy who had liver transplantation after the tumor embolization that we did for him. And this is another lady who comes to me from Bangladesh every year. She had this chemoembolization procedure some 15 or 16 times. We did TACE on her 16 times. And so basically, IR knows no age. Interventional oncology knows no age. Anybody can be treated. We don't decline or deny patients based on their age, saying that you're not fit for so and so. Pretty much most patients are fit for the interventional oncology procedures. However, we need to choose our patients wisely. Thank you so much. This is my fellow's number. If any of you would like to contact him, Dr. Irina, who got into radiology, interventional radiology, is currently with me. And if you have any doubts, you can always ask him. It's always better to ask your fellows, who are who are sailing in the same boat as yours, and they'll be able to share better. Thank you so much once again.
Thank you so much, ma'am, for the talk. Oncology is something I'm personally interested in, so I'll make sure I look into this avenue. We also have
I
Dr.
can't hear you.
Dinesh.
I can't hear you.
Hello? Am I audible?
Let me just see.
Hello?
Yes, Karthik, you're audible.
Okay. Thank you, ma'am, for the talk. Oncology is something I personally am
I don't know if anybody
interested
else
in.
can hear. I can't hear for some reason. Let me just check.
Okay. Hello?
Yeah, I can hear you now. I can hear you now.
Okay. Thank you, ma'am, for the talk. Oncology is something I'm personally interested in, so I'll certainly look into this avenue. Uh, we also have Dr. Dinesh Sharma with us now. I'd like to introduce him to everyone. So, Dr. Dinesh completed his MBBS from BJ Medical College, Pune, and his postgrad in radiology from GMC Nagpur itself. He's currently pursuing his super specialty in neuroimaging and interventional radiology from the National Institute of Mental Health and Neurosciences, Bangalore. He'll be walking us through interventional neuroradiology and its applications. Glad to have you on board with us, sir. If you'd like to take over.
Yeah, thank you, Karthik. Let me share my screen. Yeah, I hope my screen is visible to everyone. And am I audible to everyone?
Yes, sir.
Okay. So thank you everyone for inviting me for this talk. I'm a second year DM radiology resident here in Nimhans. And actually talking about the woman neurointerventionist who are there working. Like I heard the talk of Dr. Deepa Shri and Dr. Barbara ma'am. So it was a wonderful talk. And I think if you want to see a woman neurointerventionist, you can visit KM Hospital. I had a privilege to work under Dr. Rashmi Saraf ma'am. She was my mentor there, and I worked uh, under her for 1 year, and it was a very very grateful experience. Okay, so let's start with the interventional neuroradiology. So this is one of the branch which has which has evolved in a decade like anything, and it has given so much benefits to the patients who are who will be chronically debilitated if not treated within hours of arrival in the hospital. And I have seen those people who come with a lying down posture, and they'll go on walking like next day after the procedure. So what all the cases which I have witnessed, and what all I am interested in is a stroke intervention, which we commonly do here in Nimhans. We have a dedicated stroke team which consists of a neurologist, neurointerventionist, and a neurosurgeon as well. And we attend the stroke calls as early as possible. Sometimes we are the first one from radiology side to attend the patient, and to see the patient and to diagnose the stroke case, and to then get the imaging done as early as possible, because time is brain. And as all you know that in India, the awareness about the stroke is very less, and sometimes you have to explain the patient, as told by Dr. Deepashri madam, that you have to tell the patient that it's like a cardiac intervention. You are going into the brain artery and removing the embolus or a thrombus with the percutaneous approach, like a coronary intervention which has been done for the cardiac attacks. Okay, then brain vascular malformations also we are treating very frequently here. And then aneurysms, definitely first in 1990s, it was the clipping which was done for the aneurysms, and many of the patient will may land up in comorbid conditions after clipping, because it's a very invasive procedure, and it will require a craniotomy, and then it will sometime lead to the sacrifice of the parent vessel. And as you know that even a small vascular compromise in brain can lead to a devastating complication. And this coiling of the aneurysm has come into play when Dr. Guglielmi had introduced GDC coils, and these coils were then the randomized control trial had come regarding the aneurysmal coiling and the clipping, and it has shown to be of the similar efficacy in preventing the re-rupture of the aneurysms, as well as preventing the future morbidities. However, it has been shown that the endovascular treatment of the aneurysm has less morbidity as as it comes to the hospital stay as well as the MRS course. Then I have seen some venous stenting cases where we had done venous stenting for idiopathic intracranial hypertension cases. We measure the gradient across the venous stenosis. In idiopathic intracranial hypertension, what happens is there will be increase in the intracranial pressure, which will lead to some pressure effects. Like in optic nerves, there will be gradual progressive decrease in the vision of the patient, and there will be a vicious cycle of increased intracranial pressure leading to venous stenosis, and then venous stenosis itself leads to decreased CSF absorption, and which will itself cause again raised ICP. So this vicious cycle can be taken care by doing a stenting across the stenotic segment of the transverse sinus or at the transverse sigmoid junction, as we see commonly. And these patients, I have seen the vision coming back to normal or near normal after stenting, immediately after stenting, at the time of patient going back out of the cath lab. Then I have seen many of the sclerotherapy cases in KM hospital where we had a very good exposure of maxillofacial vascular malformations like lymphangiomas and hemangiomas, facial hemangiomas, then your tongue hemangiomas, which way we used to do sclerotherapy with bleomycin under a fluoroscopic guidance, and it was giving a good clinical result. Then I have seen few of the pediatric brain vascular malformations like pile AV fistulas. AV fistulas are nothing but the malformations. It's a congenital malformation where artery will get directly connected to the draining vein rather than being having an intermediate brain parenchyma to supply or a capillary bed to supply. So in those cases, just embolizing that fistula will have a reduction in the patient symptoms. I have seen few cases of maxillofacial AVMs being embolized pre-operatively, and then for cosmetic effect, they were taken care by the plastic surgeons. So it was a very good team effort. Then some intracranial extracranial stenting cases where if as you all know that carotid endarterectomy as well as carotid stenting has shown similar effects as far as the literature goes, and in prevention of the strokes wherever there is a disease of the carotid bifurcation or proximal ICA. Then still intracranial carotid or MCA stenting has or vertebral artery stenting has shown to be equivocal to the medical treatment, and still it has to be streamlined with some ongoing trials. Then I have seen quite a lot of spinal vascular malformations like dural arteriovenous malformations, where there will be these are what is a dural arteriovenous malformation is a aberrant connection between a dural artery which should supply dura, but it is now draining directly into the veins which are draining the spinal cord, and because of this there will be a pressure gradient and there will be increased pressure in the veins, which will lead to the further pressure changes in the spinal cord. Then I have seen few vertebral augmentation procedures like kyphoplasty and vertebroplasty done here at Nimhans, and have shown to be quite effective in painful fractures. Then preoperative tumor embolizations. As of now, here though we don't do that much of JNAs or vascular malformations, but as of the KEMA exposure is concerned, JNA embolization was a routine procedure where we used to embolize juvenile nasopharyngeal angiofibromas routinely, and next day patient will get operated without a significant post-operative or intraoperative blood loss. So coming, I will directly jump onto the cases because most of the techniques have been shown by Dr. Deepashri ma'am, and I think nowadays people have started doing neurointervention with the transradial approach many times, but still we are very much averse with transfemoral approach, and we are using transfemoral only here in NIMHANS. So this was a case I had witnessed in KEM. This was a 1 month female child who had some cough, and thereby thereafter he progressed to have a increased respiratory activity, and then that sucking reflex was not very good, and then as we reviewed the history, patient was diagnosed of venous malformation antenatally, and he was in failure with uh, uh, patient was discharged from the previous hospital, from outside hospital on digoxin, but still patient had features of failure, and his O2 saturation was 96%, as some failure changes was seen on the auscultations, like crepes and wheeze were audible, and as you see this chest x-ray, there is definitely a cardiomegaly there, and perihilar haziness is also there, so definitely there is some cardiac failure changes which are going on. So we evaluated the patient with MRI. You can see here that there is a definite atrophy of the brain. There is increase in the CSF spaces around the brain, and as you can see that there is a large dilated venous structure here in the region, in the pineal region, and it is draining into the straight sinus, which is also appearing to be dilated. So all these features we attributed to venous hypertension because of this galenic malformation. As you can see here, the CSF spaces which are dilated are very disproportionate to the age of the patient. Then we also evaluated the patient with HRCT, so that as we were having some doubt about the infection which is causing aggravation of the CHF, but as such there was no infection, though there were some changes of back pressure hypertension. Now then we directly proceed with the DSA as requested by the pediatricians, that patient was landing into failure again and again, and he was on multiple diuretics as well as multiple inotropic drugs. Then as you can see here, there are multiple dilated tortuous posterior carotid arteries which are directly draining into the dilated vein. Here you can see a dilated ACA draining directly into the galenic system. So all you can see is in an arterial phase, you should not see any of the venous structure. But as you can see here, there is a shunting going on, and it's the arterial pressure is directly being given up to the venous system, and this increase in the venous pressure has led to the brain changes which we have seen on MRI. So now coming to the these are the vertebral angiograms. As you can see here, there is a dilated postcoronal vein which is directly going and draining into the and is connecting to the dilated median prosencephalic vein. So we went ahead with the first session. As you can see, the cast of glue here, and we had one complication there that time. There was, as you can the patient's age was 1 month old, and in the 1 month old child, you can imagine the caliber of the vessel. The endothelium and the blood vessel wall is not totally matured, and it is definitely very prone to get damaged during the catheterization also. And we had one intraprocedural rupture, but with contrast excitation, as you can see here, we had taken this dynacity during the procedure only, and as you can see here, the whole of the cisternous spaces in the pre-interpeduncular cistern, in the in the ambient system as well as in the cortisomal system, there is a lot of contrast extraction is going on. So immediately we had to proceed with the embolization. For the first session, patient was kept intubated and was observed, and then gradually went off. But the thing was, as we were trying to wean off the inotropic support, patient was again landing up into failure. So in the meanwhile, we discussed it with our pediatric team. So first of all, we had a complication during the first session, so we were a little bit hesitant to go for the second session. But as there was again and again there was patient was going into failure, then we decided to go ahead with the second session of embolization. This time we went ahead with the ACA supply. As you can see here, this is the post embolization angiogram. The ACA which was draining into the galenic system has the supply has been cut off. In vein of Galen malformation, it is not mandatory to get a good angiographic outcome, but rather than that, a clinical outcome is important. And as we can see here, the maximum part of the shunt has been taken care by this ACA embolization. So we thought we will stop at this stage and let the baby come out of the anesthesia, and we'll try to wean off the inotropic drugs. And as you can see, this was a follow-up X-ray at 6 months, I guess, and you can see the perihilar haziness which was there previously. It has now come back to normal, and there is some reduction, though there is some cardiomegaly now also, but still there is reduction, and the X-ray picture look good as compared to the previous one. So this was the baby, and we had planned next session at 10 months of age, and baby is fine now. This was a picture shared by parents. Now coming to the second case, as I told you, the maxillofacial AVM was a good there was a good exposure in KEM, and this was one of the case which I wanted to show you people. So this was an 18-year-old female patient with a forehead swelling which was there since 13 years. Patient was reluctant to come to the hospital, but because patient had some social implications, so patient came to hospital, and this was her complaint, that forehead swelling. That clinically that swelling was pulsatile, and was you can actually hear a gush of sound, the blood going through it on the stethoscope. So this was the clinical picture. You can see the redness over it, and the swelling was pulsatile clinically. As you can see in these coronal images, there are multiple dilated vascular channels in the region of the nasion, and these channels also appears tortuous. So we went ahead. So it looks, the provisional diagnosis looks like a AVM, and the patient was also evaluated for a intracanal extension or any intracanal supply, which was not there. So we went ahead with the cerebral angiography. Here we had taken a common carotid injection. As you can see here, there are multiple tortuous vessels arising from the facial artery, which are going towards the nasion. There are multiple tortuous vessels from the frontal branches of the STA, which are going towards the nasion, and there is supply from the ophthalmic also. This is a later a later phase, some delayed phase, and you can see the venous structure filling here. And as the dictum goes, in these cases, it is better to go through the percutaneous approach, and if you can embolize at least 80-90% of the AVM, then it's very easy for surgical resection. our plastic surgeon colleagues were hesitant to operate without embolization because they had seen the previous cases where they had a lot of bleeding and patient required frequent blood transfusion. So we went ahead with the embolization, percutaneous embolization. We punctured the nidus with multiple scalpel needles, and frequent angiograms we had taken. This was the post preoperative embolization glue cast. As you can see here, some of the glue because of the high flow had flown to the lungs, but it was asymptomatic, and there was at least 90% achievement of the AVM embolization. This was the lateral glue cast. As you can see here, multiple punctures we had taken, and we had taken at least 20 to 30% glue. Then post-operative angiograms, you can see here, this is the glue cast, and we had left some posterior part because there was the ophthalmic artery, which is also supplying the AVM, and we left that part for the surgical resection to be taken care of. So this was the post embolization. You can see the swelling has increased because of the glue cast, and glue itself is causes some endothelial necrosis and will lead to inflammation. Then this is the post surgical. During the surgery, no bleeding as such, any inadvertent bleeding was there. Patient didn't require any blood transfusion also, and you can see the clinical picture. It's outstanding. Now coming to the proper neurointerventional common procedures which are taken care in NIMHANS, because we as a typical neuro interventional center, we have quite a lot of referral for this kind of cases. So this was a 45-year-old male patient who had a chronic headache and has come to us for routine checkup. We evaluated with CT. On CT, there was a hyperdense mass globular mass lesion which was there, and it was in the region of the sella and suprasellar region. This is a CT angiographic image where you can see a globular contrast filled outpouching arising from the ICA. This is the ICA. This is the right ICA. This is the left ICA, and you can see a large aneurysm arising in the suprasellar region. Maybe it is clear on these images. You can see here this it is actually coming in the supraclavicular region, as well as it is projecting into the sellar region, causing some bone resorption. So we went ahead with the DSA, and as you can see, it's a partially thrombosed giant cavernous IC aneurysm. It's a wide neck aneurysm. So and it was a unruptured aneurysm. There was no SH as such, and so as standard treatment, and as of if you go back 20 years back, and treatment for this aneurysms was a AMSA bypass, where surgeon has to do a day-long surgery, and patient being many a times and landing into the graft failure and into devastating complications like hemiplegia. So nowadays the standard treatment what a neuro interventional radiologist can offer is a flow diverter. So we went ahead with the flow diverter. We had crossed the lesion, and you can see the markers, distal markers, as well as the proximal markers of the flow diverter. So in a venous phase, you can see after the flow diverter deployment, there is some stasis going on in the aneurysm, and this was the flow diverter which was deployed, and the aneurysm was taken care of. On patient was on continuous follow-up, on 1 year follow-up. As you can see here,
Excuse me, sir.
Yeah.
Sorry to interrupt you. We are in a little bit of a time crunch, so can I request you to wrap up in the next 2 to 3 minutes?
Yeah, definitely. Okay.
Thank you, sir.
So we can see here that the aneurysm has totally thrombosed, and the ICA fluid has totally being maintained. And on follow-up, you can see that this is a MR angiographic image, and there is no as such any aneurysm seen, residual aneurysm seen. So this was a this is the this is the this is the our this is our this is the new technology which we can offer to the patient, where patient can have a minimally invasive procedure for such a giant aneurysm. Now coming to the cases which I like the most, the stroke. So this was a case where a 37-year-old patient came with complaints of left side hemiplegia, and he was within the window. But as you can see here, the aspect score which we usually see on CT brain plane images is very poor. As you can see, a large hypodensity in right MCA region, and so we didn't went ahead with the intervention. This case I wanted to show because this was if patient had been there, like if we see retrospectively, and 10 years back, if we see the fate of these patients, then patient would have gone into the acute phase of a large infarct with a large MCA clot here. So this was a case where we didn't went ahead with the intervention, and as you can see, this was the clinical progression of the patient. He has lost quite a lot of right cerebral hemisphere, and this is a flare image showing a large right MCA territory infarct. So patient came with follow-up. Patient's MRS was modified Rankin scale was 4. Patient was not able to do his routine clinical activity. So this is the importance of a neurointerventionist, where you, if patient would have come to the hospital as early as possible, and we would have been able to achieve a good reconvalescence, then this part of the brain which has been damaged would have been saved. So this is the unfortunate progression if you don't do reconvalescence within the expected time period, and many of the times patient will end up in a high modified Rankin scale. Now, the patients which we were able to save, this was a 65-year-old female with a right side weakness, NHS was 15, and a patient was came within a window period 6 hours to the hospital. Patient was a chronic smoker and alcoholic, and as you can see here, the brain parenchyma looks very much preserved. As you can see, some chronic ischemic changes are there on the right side, but on the left side it looks quite preserved. So as patient came at a borderline period of 6 hours, we went ahead with the MRI, and as you can see here, there are few patchy infarcts in the left MCA territory, but as such, all the brain parenchyma which is supplied by the left MCA territory is now is alive. So we went ahead with the DSA, and as you can see here, there is a terminal IC occlusion post after the origin of the PCOM, and this looks a little bit scary because there are some atherosclerotic changes in the intracranial segment. We went ahead with the stent retriever technique for first pass aspiration. As you can see here, the vessel which was supplying a large territory which was occluded in the pre-thrombectomy angiogram. Now you can see it has opened, and we were able to achieve a full TK3 recanalization. Coming to the last case, this was a 43-year-old chronic smoker, alcoholic with right-sided weakness, came to the hospital within window period with NHS of 15. As you can see here, the CT aspect looks fairly good, around 8, and there is a lot of brain to be saved. And this hyperdense city you can see in the region of the left MCA territory, which is usually suspected to be a thrombosed segment. We went ahead with the CT angiography, and you can see here, this is the IC terminus, this is the MCA, and this is the ACA. And in MC, you can see here, after the origin of the MCA, there is a full cutoff of the MCA, and there is no distal opacification of the distal M1 segment. But as you can see here, there is a good collaterals coming from the cortical branches, and it is filling the distal branches of the MCA. So good collaterals is a good indication, because that is the brain which we call as a penumbra, and which we can save with the mechanical thrombectomy. We went ahead with the MRI, and we can see here there is very few patchy infarcts in the left MCA territory. This was the we performed a diffusion perfusion to show the diffusion perfusion mismatch, and to show how much is the brain which is at risk. We performed a perfusion study. This is a cerebral blood volume map. Here you can see there is little bit asymmetry, but as such the brain is showing a preserved cerebral blood volume. And as you can see in this mean transit time map, you can see here that it's a prolongation of the mean transit time time in the large area of the brain on the left side. This was a arterial spin labeling study, where we can see here there is decrease in the flow on the left side. However, the right side, the flow is maintained. So we went ahead with the DSA. You can see the same as that of the CT picture. There terminal ICA is bifurcating into the ACA and MCA, and there is a abrupt cutoff in the region of the M1 segment, and there is no distal position of the cortical branches. So we went ahead with the stent retrieval thrombectomy, and as you can see here, there is good distal reperfusion, and we can see here some stenosis is residual stenosis is there, which we thought as the etiology for this patient's clinical presentation, and was thought to be a atherosclerotic one. So this was a post-procedure MR, as it looks the same as of the pre-procedure, and we don't have any of the new infarcts which has progressed. So this was one of the case where I had a on-table recovery of the patient, where patient came with the left-sided hemiplegia, and we did a right M1 thrombectomy, where he had on-table regainment of the power of 4/5. Thank you very much.
Thank you, sir. That was indeed very insightful. So let's move on to the question and answer session now. Dr. Deepashri, if you could please unmute yourself, that would be great. Good morning, ma'am.
Yeah, guys, yeah, please tell me. Yeah, I just have a case. Would you mind if I just, leave in probably 2 minutes time? If you have questions, you can ask me. But then,
Yes, ma'am. We just have 1 or 2 questions which we got in the pre-event form. So
Yeah.
it would be great if you could answer them. So my first question is, what is the scope of interventional radiology in a small town away from the city?
It depends on the government, and then if they can provide us the infrastructure. You need to ask the leaders this question, and not me. Because scope of interventional radiology, all of us would be willing to work anywhere for that matter. Yeah, if you have the passion, you can work anywhere. It's not about which city, where, and all that. But all that we need is the infrastructure. But unfortunately, in India, the infrastructure is pretty bad. You all agree with that. So we don't have the facilities available. But otherwise, if the government can come up with some schemes, I mean, there are CM schemes in every city these days. If there is a CM scheme or a Modi scheme or some kind of a scheme wherein we can reduce the prices and we can extend the services to every single person of India, yes, there is definitely a lot of scope for IR.
Thank you, ma'am. That was very insightful. So the last question we received is, what can we expect from the future of interventional radiology in the perspective of nuclear medicine?
In the perspective of nuclear medicine, we started doing, it's more about collaboration. I mean, I would say not just nuclear medicine, but any other branch for that matter. It's more about collaboration. And in the perspective of nuclear medicine, there are a lot of radio, for example, radio embolization. We do something called as a transarterial radio embolization, which is in collaboration with a nuclear medicine physician. So they have the authority to get the dose for us, and then in fact they inject it into the artery. So we place the catheter into the liver, and then a nuclear medicine physician, he injects a radioactive drug. It is called as the Y90 or the yttrium-90. So like that, there is a lutetium therapy for neuroendocrine tumors. So there are a lot of therapies which are coming. So in combination or in collaboration with a nuclear medicine physician, there is a lot of scope, coming up of late. And in fact, don't forget about the nanotechnology as well, which might take over. We don't know, God knows when it's going to come up. But then yes, yeah, there's a lot of scope.
Thank you for your answer, ma'am. It was great having you with us today, and thank you for being here.
Thank you. Thank you so much for that. I'm sorry I have to rush, but thank you so much. Thank you.
Thank you, ma'am. If anyone has any more questions, we have Dr. Dinesh with us here. Please put them down in the chat box. Okay, so I don't think there are any more questions. I think we pretty much covered everything in your talk, sir. So if there are no more questions, I would like to end this session by extending my vote of thanks to our esteemed speakers, Dr. Dipashri, Dr. Dinesh, and Dr. Barbara Hamilton, for sparing time out of their busy schedules to be with us here and educate us about interventional radiology. That was a brilliant session, and I'm sure we all learned a lot from it. We are indeed privileged to have you with us here today. Thank you, Dr. Dinesh, for being here and educating us about interventional radiology. We would also like to thank all the participants for actively participating in this event and attending it. So we have a post event form which will be giving in the sharing in the WhatsApp group in an hour. And don't forget to fill it up. After that, a list of top 5 participants eligible for a certificate of appreciation will be shared in the WhatsApp group. So don't leave the WhatsApp groups. And thank you for being here. I'll now be ending this meeting in the next 2 minutes. If anyone has any questions, feel free to DM any of the group admins on WhatsApp. Thank you.